Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/VUR. This activity is supported through an independent educational grant from Merck & Company, Incorporated, Rahway, New Jersey, USA.
Hello, my name is Kaushik Ray. I'm Professor of Public Health and a consultant cardiologist at Imperial College London in the UK. Welcome to this Peer Voice activity. Atherosclerotic cardiovascular disease develops silently over many, many years, and often mild abnormalities that contribute to this are missed, and these are easy to dismiss when we consider these in isolation. And one of our clinical challenges is really to think about the patient over time and how we should appropriately intensify treatment once we've identified these patterns and these changes early on. So to start this, why don't we think about a typical patient? So this is a patient of mine, a 55-year-old male patient presenting to the accident and emergency department with a myocardial infarction. So at that point, we're going to manage this patient obviously very aggressively. He's going to have a stent, he's going to have multiple medications to try and reduce the risk of further cardiovascular events. But were there opportunities prior to this? We know, for example, before all of this happened, he was managed in primary care, and about 10 years before, he had been started on statin therapy. So, of course, now the patient is aged 55, and he's classified as a very high-risk patient. We've got to manage the patient aggressively. So, looking back, were there earlier signals present? So let's go back and look at the person now at the age of 40. They're already a smoker. Their blood pressure is not particularly elevated, 120/70, total cholesterol 4.8, and the LDL cholesterol is 4 millimole per litre. So at that time, they're appropriately started on cholesterol-lowering treatment, so a moderate intensity statin that would be expected to give you 30 to 50% lowering. So the LDL responds nicely and the cholesterol comes down to 2.2 millimoles per litre. But then over time, at the age of 45, again, another encounter with their family physician. But now, despite being on statin therapy and their LDL cholesterol remaining at 2.2, so we don't have a problem with adherence, we now see a slight change in their risk profile. They've continued to smoke, so they haven't stopped smoking as advised 5 years ago, and the blood pressure has crept up. It's now 140/76. Their HDL has fallen to 0.95. The average for a white Western male is 1.24, and the BMI has gone up, and that may be what's driving that fall in the HDL. But what's most important is now they've newly been diagnosed with type 2 diabetes, which means they are now a much higher risk than we had previously imagined, but no treatment intensification occurs. So what we now know about how risk evolves, and we can think about cholesterol years or a bit like smoking and PAC years, and Ference and colleagues were the first to really put this forward. And it's very easy to see the patient with a very high cholesterol level, but what we forget is duration of exposure. And so if cholesterol levels are high for a long period of time, then the threshold, if you will, that the blood vessel needs to reach before a heart attack occurs is going to be reached much, much earlier. But there are factors that will accelerate this whole process. So your cholesterol level doesn't need to be very high, but you might have, for example, you might be somebody who smokes, you might have hypertension, you might have adiposity and therefore metabolic dysfunction, and this accelerates arterial wall injury. So even though if you've got a so-called normal level of cholesterol, you're going to reach that lifetime threshold much, much quicker. So these mild abnormalities are not trivial, and in isolation, unless taken together, they certainly don't tell us the full story. So the typical things that we look at that should prompt reassessment are we obviously take a history from our patient, and somebody who's got a positive family history means that they're genetically much more vulnerable. So these are people whose parents, for example, father before the age of 55, mother before the age of 60 had a myocardial infarction. We recognize diabetes, smoking, and hypertension, as well as high cholesterol, as well-established risk factors. But there are other things as well now that have emerged. We only need to measure lipoprotein A once, but if that's elevated, that person's risk is much higher than we'd previously envisaged. If over time somebody develops chronic kidney disease or weight goes up or their lifestyle becomes much more sedentary, we know that other things happen. Triglycerides go up, HDL will fall, and also inflammation has emerged as a risk-enhancing factor. So all of these things should be looked at. So let's test your risk assessment knowledge. So in summary, risk is dynamic, it's not static. And what we can see from this particular patient in this case study was that the patient's cardiovascular risk was already changing and there were opportunities to intervene that were missed. And the result is that over 10 years, this person has had progression of atherosclerosis culminating in a myocardial infarction. And now they've moved from a moderate risk to a very high risk patient. If we think about this in a bit more detail, what we need to think about is the blood vessel wall and what happens over time. We're born with completely normal arteries, and so we're clearly going to be at low risk for many, many years. But over time, cholesterol accumulates, and in this particular individual, the person's moved from being moderate risk to high risk at the age of 45 and to a very high risk patient at the age of 55. So atherosclerosis is progressive. We can see from the recent work that we've published that if we look at trials of primary prevention, taking statins and non-statins, and over 105,000 individuals, then the amount of benefit that we get from cholesterol lowering is a bit like thinking about your pension. So how early you start determines how much benefit you're going to get. So if you're a low-risk individual, let's say, with an annual risk of less than 1% per year, if I invest 1 millimole of cholesterol lowering, then over about 5 years, the risk reduction is 36%. If my annual risk is 2% per year, that same 1 millimole per litre only gives me 25% risk reduction. And if my annual risk is now 3% per year, the return on that investment of 1 millimoles is only 13%. So what that means is, depending upon how much atherosclerosis and how much risk I have, I can actually quantify what I need to invest. So in a low-risk individual, if I want to achieve a 25% risk reduction, I only need 0.36 millimoles of cholesterol lowering. But if I wait for more disease or risk factors now to emerge, now to achieve 25% benefit, I only need 1.7, I need more, I need 1.72 millimoles per litre. And if I wait even longer, and I have a person that's now 3% per year risk, then I need an over 3 millimole lowering of cholesterol. So based on the evidence presented, let's consider an important question. To summarize, long-term exposure matters, risk factors interact over time, individual encounters may underestimate the evolving landscape of cardiovascular risk, and the key question to remember in this particular patient's life course is, were there moments in their timeline where reassessment might have changed what we did and their future prognosis? Welcome back, everybody. So let's take another look at this particular patient and their cardiovascular history and their trajectory of risk. So starting at the age of 40, we know this individual was a moderate risk patient. But we also know that by the age of 45, because of the emergence of different risk factors, this person had moved up risk categories to now become a high-risk patient. And knowing what was going to happen at the age of 55, looking back now at that particular age, that now feels like a missed opportunity for intervention when that person was 45. We know that cholesterol lowering is important, and you might wonder, how well are we actually doing globally? Well, we're not doing particularly well around the world. we have risk-based cholesterol goals. The higher the level of risk, the lower the cholesterol level needs to be. And global evidence now really shows us that less than 1 in 3 high-risk patients achieve their risk-based cholesterol goals. And this is really important because our patients evolve, and some individuals would be absolutely fine. But if risk evolves and treatments don't evolve to match that level of risk, then the outcomes that we see, like in my patient, become almost inevitable. So our treatments have to evolve in a proactive way. I want to take us back and reconsider what the cholesterol goals were at each stage of their life course. So at the age of 40, this individual would be considered moderate risk. So their LDL cholesterol goal was 2.6. We achieved that when we started and put them onto a moderate intensity statin. Their LDL was 2.2, so we're all very happy with that. But at the age of 45, 2.2 is no longer enough because this patient has developed diabetes, has a low HDL cholesterol, their BMI has gone up, and their blood pressure has increased. This now means this is now a high-risk patient, and the correct cholesterol goal or level that we want to achieve is below 1.8. And by the time this person has a myocardial infarction, their goal is 1.4. So if we revisit this case and ask ourselves, what could we have done differently at the age of 45? Well, at the age of 45, if this person is not at their goal, which is now 1.8, we would add in a second drug. They're already on a statin. Remember, the LDL's come down from 4 to 2.2. And we'd add in ezetimibe at this point to try and bring the LDL cholesterol down below 1.8. Now let's see how this aligns with your own clinical decision making. Okay, so we've added in ezetimibe, 10 milligrams now, and the patient's cholesterol level, when we reassess the patient now, and the patient is a little bit older, 46, their LDL's come down. It's 1.9. So it feels like we're almost at goal, but we're not. We really should be trying harder. And what we should be doing as per the guidelines would be to add in an injectable therapy at this point on our current pathways, which is a PCSK9 directed therapy, a PCSK9 inhibitor. So for this patient at this stage, I want to know what you would do. How would you further intensify therapy? Okay, so is cholesterol goal achievement enough, or are there specific scenarios when we might need to consider other things? So remember, this patient at the age of 55 was already on a moderate intensity statin and their LDL was 2.2. They've had a myocardial infarction. And we could follow that stepwise algorithm, going to ezetimibe, then thinking about an injectable therapy, for example, or a PCSK9 inhibitor. Well, we've now got new data, we've got guidelines that have been updated, and those data came from the Sweetheart study. And in that study, we asked the question, does it matter how quickly I achieve those cholesterol goals? And so what we showed was, for example, that patients could achieve cholesterol goals either in a stepwise way, so they got to their goals at 1 year, or they might have achieved those goals within 2 months and maintained that. And the group that did the best are the ones where goals were achieved early and, importantly, maintained. They had the best long-term outcome. And you might think, well, maybe I need to go through different steps and there's an element of trial and error. Well, there isn't, because we know from the ITACARE data, for example, that those patients who are more than 24% away from getting to their LDL cholesterol goals, they're unlikely to reach that target with currently available oral therapies if you're just adding a single oral agent over and above a statin. And we can see when we look at the totality of the data that there are some clinical scenarios where there's clearly urgency and we want to achieve goals quickly, but also you can actually look at the potency of different treatments and look at how far away you are from goal to actually guide which treatments you're going to be reaching for. So the key take-homes here are that both the timing and the distance from cholesterol goal can really help shape the cardiovascular trajectory of your patients. So, in conclusion, my key takeaways for you are that atherosclerotic cardiovascular disease is not static. It evolves over time, and our decision-making to support our patients has to evolve with it. If you have a patient who has a persistently elevated LDL cholesterol levels, they clearly have residual cardiovascular risk, and so you've got to think about reducing that earlier. As risk goes up, if you don't play catch-up, what we will do is we'll expose our patients not just to that number, but the number of years that we maintain that inadequate number, and that's called cumulative exposure. High levels in time. Think about cholesterol pack years, if you will. The earlier we intensify treatment, and in particular, guideline and goal-directed intensification, including better use of combination therapies, much like hypertension, and where appropriate, using more potent treatments earlier, that's how we're going to improve timely LDL cholesterol goal attainment. So, thank you for watching, and I hope you found this helpful.
This has been an activity published by Peer Voice.